Dr. Nader for this opportunities. And the agenda of today, we will start by hematology with Dr. Roaa and Dr. Safa. Dr. Safa, if you are ready, you can share your screen with us.
Yes, we're ready. Dr. Roaa, please share your screen. Hello, everyone, and welcome to our presentation on oncology and hematological malignancies. I'll be presenting this presentation. I'm Dr. Safa Mubarak with my colleague, Dr. Roaa alsadig. By the end of this session, you should be able to describe the incidence and prevalence of certain cancers, how tumor biology and cancer behavior is modified by age, how to assess fitness and inform decision regarding cancer treatment for older patients, and finally, the risk and benefits of treatment approaches of specific cancers in the older adult population. The topics that's going to be covered are ranging from cancer biology and aging, principles of cancer management, the assessment of older cancer patient, treatment, screening, and we will mention specific type of cancers. Next, yes, we will go through specific cancers and hematological malignancies, including lymphomas and multiple myeloma. So firstly, we're going to talk about the epidemiology of cancer. Both the incidence and prevalence of cancer increase with age. 1 in 4 deaths in the US is caused by cancer, with the median age of cancer patient in the US being 70. But interestingly, after the age 85, heart disease becomes the first killer, and the risk of cancer declines for reasons that are not yet clear. It's also important to mention that in clinical trials of breast and colon cancer, it appears that the treatment efficacy is similar in younger and older people who do not have significant comorbidities or functional impairment. So, what are the reasons for the increased prevalence of cancer with age? Some cancers are thought to develop over a long period of time, perhaps decades. And one of these reasons we can mention is firstly that DNA repair mechanisms decline with age. So when mutations occur at a cellular level, these mutations accumulate because the DNA repair mechanisms are declining with age. Secondly, immune system, uh, particularly the cellular mediated immunity, declines with age. So these combined factors of a declining DNA repair and a declining an immune system combine together and can increase the prevalence of cancer with age. Next, we're going to discuss the different characteristics of cancer with age. Older people are more likely than other adults to present with advanced stage cancer. Epidemiology data does not support the notion that cancers in older people are less aggressive or slower in growing. But in contrast, animal data do suggest that reduced tumor aggressiveness with age. But for most cancer types, the molecular biology and clinical behavior are similar across all the age span. We also want to discuss the ethnic differences in cancer epidemiology. Overall, we should know that Black Americans have the highest rates of cancer in comparison to all other ethnic groups. Just like it's shown in the slides, there are the percentages comparing the risk of cancer between Black Americans and other ethnicities. The cancer incidence in Black Americans is 10% higher than in white Americans, 50 to 60% higher than in Hispanic and Asians, and 50% higher than in Native Americans. Also, cancer mortality in Black Americans is 30% higher than in white Americans and more than 50% higher in Hispanic, Asian, and Native Americans. And also, it's important to note that Black Americans with cancer have shorter survival time than white Americans at all stages of diagnosis. And the relative 5-year survival rate is higher among people diagnosed at younger age than at those diagnosed at older age. And we could think of it as younger people have better health, they have stronger immune system, and they have greater tolerance for intensive therapies. And they also have fewer comorbidities in comparison to older people. And as a result, we can notice that 50%, 52% among Black Americans diagnosed before age 45 and 43% among those diagnosed after the age of 75. And some data suggest that when quality of care is similar, the outcomes of cancer survival rate between Black and white Americans become similar, and this have a systemic of evidence, grade B, which is a moderate level of evidence. Okay, so now we're going to talk about the principles of cancer management. Randomized clinical trials that establish the safety and efficacy of treatments for cancer have included few older patients aged 75 and over, and even fewer comorbidities. That means that we have a clinical gap and a lack in evidence-based guidelines in regards to patients, older patients with cancer for cancer management. But the good news is that newer geriatric-oriented trials are now focusing more on the symptom reduction and quality of life outcomes than on life expectancy. Because as mentioned earlier, the earlier research focused on the treatment efficacy, so they were more focusing on the life expectancy. Another point is that the surveys indicate that when fully informed, most older patients choose life extending treatment even at the risk of toxicity. Okay, because of physiologic changes in older adults, for example, the declining in glomerular filtration rate, there is a potential of an increase in adverse events associated with treatment. However, acute toxicities may actually be less prominent in this population. So it's more like these toxicities happen from a prolonged exposure to treatments. So and due to the declining of physiologic changes, adverse events happen in this older population. And due to the absence of evidence-based guidelines, as we mentioned in the previous slide, oncologists are often faced with the challenge of making management decisions on older adults. So, appropriate treatment for cancer can be safe and effective in older adults if an adequate assessment is done and appropriate precautions are undertaken. For example, to do a comprehensive geriatric assessment is considered the gold standard for evaluation of the older patient, and individualizing treatment decisions is important because, as I mentioned, there is an absence of evidence based guidelines. So, oncologists need to focus on individualizing treatment. If you want to check the guidelines of both the assessment of older patients with cancer and treatment, you can check the National Comprehensive Cancer Network Older Adult Oncology Guidelines. And here's the link. You can check it after the session. So next, we're going to talk about the assessment of the older cancer patient. There are many tools that are used for assessment of the older cancer patient, and one of these tools is the Kronovsky performance status and the Eastern Cooperative Oncology Group, which is the ECOG performance measures. And these measures correlate with treatment toxicity, but it's important to know that these measures alone does not predict outcomes. So you need to combine these tools with geriatric assessment, because geriatric assessment can aid in detecting issues related to cancer management that could go unrecognized otherwise, like polypharmacy, for example, because polypharmacy can increase the risk of adverse events from chemotherapy and increase risk of non-adherence. Okay, so there are factors that independently associated with worse overall survival, and these factors include low albumin, ECOG performance status, which is the Eastern Cooperative Oncology Group performance status, and this performance status relies on the functional impairment, and you can check it later. If they have an ECOG performance status of more than or equal to, this is considered a worse overall survival. There is also positive geriatric depression screening, advanced stage of disease, malnutrition, advanced age. All these factors are associated with overall worse survival. So geriatric assessment requires an interprofessional approach that aids in developing a patient-centered treatment plan. And this geriatric assessment reviews the global health of the patient, including functional status, comorbidities, cognition, nutrition, weight loss, polypharmacy, psychological status, social support, and geriatric syndromes. And these same variables can be used to predict toxicity from chemotherapy. Okay, so now after we talked about this overview of the cancer in the older patient, we want to talk about the treatment options for geriatric patients with cancer. The current forms of cancer treatment include surgery, radiation, chemotherapy, hormone manipulation, and biologic therapy. And it's important to know that age alone does not preclude any of these approaches. But because of normal changes with age in certain organs and comorbidities, special considerations are warranted. Okay, so firstly, before we talk about these treatment options in details, we can talk about cancer screening. Cancer screening can be considered for breast, colon, lung, and cervical cancer. And you can check the United States Prevention Task Force Services, which is the USBTFS guidelines, to check, like the guidelines for age recommendations for screening. Another point is that prostate cancer screening is controversial at any age and is unlikely to benefit someone with less than 10 years of remaining life expectancy. Assessing remaining life expectancy should involve a comprehensive evaluation of health status and include the functional impairment, disability, comorbidity, and geriatric syndromes. So it's important to consider life expectancy and the risk of testing, overdiagnosis, the risk of overtreatment when recommending cancer screening for older adults. Okay, so firstly, we're going to talk about chemotherapy. Chemotherapy generally adds complexity to the treatment of older patients with cancer because older patients have multiple comorbidities and they use multiple medications. And we're going to discuss briefly some of the issues related with chemotherapy. For example, firstly, there is the pharmacokinetic changes. As we know, as I mentioned earlier, with advancing in age, there is a reduction in glomerular filtration rate, and this reduction can contribute to more severe toxicity from different chemotherapeutic agents like cisplatin, lenalidomide, and capecitabine, which are sometimes contraindicated or need dose adjustment with older adults who have renal insufficiency. Next, there is the pharmacodynamic changes. Research suggests that there is possible enhanced resistance with age to anti-tumor agents, and also with advancing age, there is an increased expression of the multi-drug resistance gene. And murine model studies, which is studies done in mice, shown that there is an increase in tumor hypoxia with age. And we know that when there is an increase in tumor hypoxia, angiogenesis is more likely to happen, and the more angiogenesis happen, the more aggressive and rapidly growing the tumor is. Next. Okay, chemotherapy is also one of the challenges of using chemotherapy is that chemotherapy is associated with many toxicities, including, I'll mention them briefly, like mucositis, cardiotoxicity, peripheral neurotoxicity, cerebellar toxicity, and so on. And there is also a risk of myelotoxicity, and we know that myelotoxicity from chemotherapy will result in bone marrow suppression. So cancer patients will be at risk for neutropenia and thrombocytopenia. And neutropenia gonna cause the patients to be more prone to infections. But the good news is that recent advances. Next. Okay, but the good news is that the recent advances shown that the use of granulocyte colony-stimulating factors and granulocyte monocyte colony-stimulating factors have reduced the incidence of neutropenic infections in patients receiving intensive treatment, and their effectiveness does not appear to be diminished with advancing patient age. Okay, so now we talked about chemotherapy. The next form of therapy for geriatric cancer patients is hormonal therapy. Hormonal treatment is effective in cancers of the breast, prostate, and endometrium, and most of these are well tolerated by older adults. So firstly, we're going to talk about breast cancer treatment, hormonal therapy. Tamoxifen is used as an adjuvant therapy for breast cancer. It has a positive estrogen-like positive effect on cardiovascular risk factors and bone disease, but also it's important to note that this positive effect also extends to the uterus and can cause uterine cancer. So women who use tamoxifen should be informed to notify doctors in case of any abnormal vaginal bleeding. The next option of hormonal therapy for breast cancer is aromatase inhibitors. They also use as adjuvant therapy for breast cancer, and they are more effective than tamoxifen and well tolerated. But there is a risk of osteoporosis and fractures are more common in patients on aromatase inhibitors. Okay, regarding prostate cancer, hormonal therapies are considered the first-line treatment for systemic prostate cancer, and they significantly decrease testosterone levels. But this decrease in testosterone level results in many consequences that include metabolic syndrome, increased risk of metabolic syndrome, cardiovascular disease, osteoporosis and fractures, and physical performance decrements. Okay, an older older men can be subjected to adverse events of hormonal therapy for many years, given the indolent and slower course of prostate cancer. So it's very important that prior to starting treatment with hormonal therapy for prostate cancer, we should assess the patients for life expectancy, prostate cancer severity, and overall health. Because, as I just mentioned, older men will be subjugated to adverse event because of the prolonged use of this hormonal therapy because of the long course of prostate cancer. Okay, so after we talked about chemotherapy and hormonal therapy, the third option is the biologic and targeted therapies. Modulation of immune response is an attractive option in treating older patients whose natural defenses may be impaired by immune senses. And immune senses is the weakening of immune system that is associated with increase in age. And examples for these biologic and targeted therapies is recombinant alpha interferon that is used in melanoma and renal cell carcinoma and hematologic malignancies. There is also interleukin 2 that is used as a curative intent for advanced melanoma and renal cell carcinoma. But these agents have been replaced by neuroimmunotherapy agents. Okay, so targeted therapies, from their name, the name of targeted therapies give you a clue that they target a specific receptor involving cancer signaling. And toxicities with these biologic and targeted therapies occur with monoclonal antibodies. And these toxicities range from serious toxicities like autoimmune mediated colitis to milder ones like hypertension and shortness of breath associated with first infusion. Okay, next. Yes, and there is also some adverse effects like vascular adverse events. Next. Okay, so these are the general adverse effects that happen with biologic and targeted therapy. I will go through them briefly. They include cardiovascular risk factors like hypertension, QTc prolongation, cardiotoxicity, pericarditis, myocarditis, and so on. There's also dermatological side effects like acneiform rash, maculopapular rash, hand-foot syndrome, keratoacanthomas, and other cutaneous squamous cell carcinomas. And also peripheral neuropathy, dyslipidemias, and fluid retention. There's also myelosuppression. Yes, there's all a previous slide. Okay, myelosuppression, thyroid dysfunction, proteinuria, arterial thromboembolic disease, electrolyte disturbances like potassium and magnesium. Myelosuppression, let's go. Dyslipidemias and fluid retention. Okay, so after we talked about hormonal therapy, chemotherapy, and biologic and targeted agents, the next form of therapy is radiation therapy. Radiation therapy is safe and effective in older patients, and this has a scientific evidence level A, which is a high level of scientific evidence. For almost 5 decades, radiation therapy have been used as an alternative to surgery in post-surgical candidates, mainly patients of more than or age 65. But there remain concerns when treatment with radiation involves irradiation of the whole brain or pelvis, but no systemic investigation has categorically substantiated these concerns. Okay, finally, the final treatment option that we're going to talk about is surgery. And age itself should not preclude elective cancer surgery, and age itself should not preclude any type of the former treatments that I've mentioned. So age alone is not a factor to exclude any of them. But it's important to note that with advancing age, the length of hospital stay and time of full recovery becomes more prolonged when using surgery. Advances such as endoscopy, spinal anesthesia, laparoscopic surgical technique, laser and photodynamic therapy, and neoadjuvant chemotherapy can benefit older patients. The trend to manage cancer without performing surgery may make us avoid the complex rehabilitation and be of special value for older people. Okay, finally, we're going to talk about quality of life issues. The quality of life instruments have not been adjusted to the special need of the older people because the questionnaires that are used in quality of life instruments are very lengthy and complex and may overburden some older people. So quality of life research might aid the choice between interventions yielding comparable survival. For example, measures of quality of life adjusted survival or quality adjusted time without symptoms or toxicity are important to consider for adults of more than or equal 70 years, and research is needed in the melding of geriatric assessment and quality of life instruments. So Right, next. Okay, so right now we finished talking about the prevalence, incidence, and screening and treatment options for cancer in geriatric patients. The next slides will be presented by my colleague, Dr. Roa. Dr. Roa, you have the floor now. Thank you.
Well, thank you, Dr. Safa. Hi, everyone. My name is Dr. Alsadig, and I'm going to be presenting the rest of this presentation. Firstly, we're going to talk about epidemiology of specific cancers. We're going to talk about this for both women and men. So, the three most commonly diagnosed types of cancer in women are breast, lung, and lastly, colorectal. And the three most commonly diagnosed types of cancer in men are prostate, lung, and lastly, colorectal. Globally, regarding breast cancer, a third of breast cancer cases are seen in patients who are more than 65 years old, and in more developed countries, this proportion is actually rising to more than 40%. Advanced age at diagnosis is associated with more favorable tumor biology, and this indicated by increased hormone sensitivity and lower grades and proliferative incidence. But actually, older patients sometimes are likely to present with larger and more advanced tumors, and this could be due to undertreatment and complexity of their health conditions. Regarding treatment, there is three options for breast cancer in geriatric population. First, for patients with localized cancer, the evidence supports surgical treatment. It is actually better than primary hormonal treatment. For breast for the second option, breast conservation treatment, which consists of breast conserving surgery like lumpectomy or partial mastectomy with postoperative radiotherapy, they are now recommended as the standard of care for all patients of all age with early disease. And the third option is total mastectomy, which remains a surgical option for all the patients who preferred over breast conservation treatment and also for those who decline or are not candidates for post-operative breast radiotherapy, and they also should be considered in patients with large primary lesions. I'm going to talk about specific points regarding management in breast cancer for older women. First, the need for complementary axillary lymph node dissection after a positive sentinel node is found. And actually, data suggests that sentinel node sampling is just as accurate as axillary dissection and also considerably less toxic. Second, the irradiation after lumpectomy. Due to the local recurrence rate that decreases with age, irradiation after lumpectomy considered to be inconvenience and the cost of radiation therapy may outweigh the benefits. And lastly, adjuvant hormonal therapy is actually recommended to be more than 2 years for these patients. Regarding the initial management of metastatic breast cancer, women who are more than 65 years old with a metastatic hormone receptor positive breast cancer are more likely to have effective palliation with hormonal therapy. For chemotherapy, it has also been shown to be safe and effective in this group of patients, and actually, it is more used in patients with visitor crisis. After talking about breast cancer, we're going to talk about lung cancer. Lung cancer increasingly common in women for reasons that are not well understood, but it could be due to higher smoking rates. For patients who are presenting with stage 4 disease, here the goal therapy is palliative. And for patients with lesion in a location that precludes surgery, radiation can result in long-term survival. Also, chemotherapy has been shown to produce clinical responses and provide effective palliation for a portion of patients with metastatic disease. I want to mention that immunotherapy is also an option for patients with advanced positive PDL high tumors and actually showing improved outcomes and less toxicity than the chemotherapy. For small cell lung cancer, it is often treated with chemotherapy and or radiation therapy without surgery depending on the stage. And for brain metastatic relapse, which is common, there is newer radiation techniques being developed to minimize longer-term neurocognitive effects. After talking about breast cancer and lung cancer, we're going to talk about colon cancer, which is the third leading cause of cancer in the United States and the second leading cause of cancer deaths. Actually, two-thirds of cases occur in people who are more than 65, and more than 90% of cases occur in people who are more than 50 years old. For women are more likely to, to have colon cancer than men in the right side, and colonoscopy should be performed in all cases of hematochezia, acute GI bleeding, iron deficiency anemia, or even melena after a negative upper endoscopy. So colonoscopy has become the mainstay of prevention of colon cancer, and this is due to the direct visualization of the entire colon in biopsy. And I want to mention polyps that may bleed or predispose to cancer. They are neoplastic adenomas and non-neoplastic like hyperplastic polyps. And I want to highlight that old age and male gender are the major risk factor for these polyps. Now let's talk about the 3-year interval for surveillance. A 3-year interval for surveillance colonoscopy. It is safe and cost-effective for most patients with adenomas. For example, small tubular adenomas requires 5-year follow-up. Large villous adenomas requires 1-year follow-up. Negative screening or surveillance colonoscopy requires 5 years follow-up. For patients with colorectal cancer, they should also have a regular colonoscopic surveillance for adenomas that is starting 1 year after surgery because these patients have adenomas or cancer recurrence rates of 25 to 30% at 3 years. Lastly, we're going to talk about management and treatment for colon cancer. Surgical excision may be adequate for lesions that are confined to the colon, but if there is regional lymph nodes, postoperative adjuvant chemotherapy should be also used, and this has reduced reoccurrence by 40% to 50%. As we mentioned earlier, age should not be considered a contraindication for the surgery. For patients with localized rectal cancer, the standard of care here should involve a multidisciplinary approach. And for stage 4, which is metastatic colorectal cancer, the standard of care here should include systemic chemotherapy with or without antibody therapy and surgical intervention. Now let's talk about gastric and esophageal cancer. Approximately 60% of esophageal and gastric cancer arise in patients who are 65 years old. Fit older patients with resectable disease should be considered for preoperative chemotherapy with radiation or perioperative chemotherapy with surgery. We should also highlight the importance of a multidisciplinary approach, which include oncology, radiation oncology, and surgery. This is very important from the beginning of the decision-making process. And for older patients with recurrent and metastatic disease, palliative chemotherapy are not only improve overall survival, but they also improve the quality of life. In the upcoming slides, we're going to talk about prostate cancer. The prevalence of prostate cancer in men more than 75 years old is over 1 million, with more than 60% of all new cases are actually diagnosed in men who are more than 65 years. And I want to mention that most men with prostate cancer die with the prostate cancer, not from it. And this is due, as Dr. Safat mentioned, that prostate cancer has actually a slow progressive course. But nowadays, with increasing life expectancy, older men may experience symptoms from the progressing prostate cancer. So, watchful waiting is the most common approach, especially for localized disease with life expectancy less than 10 years and if the patient has significant comorbidities or the tumor is small and well to moderately differentiated. So the treatment option for those patients is androgen deprivation therapy, which is the initial management for these patients, and it is associated with numerous adverse events like hot flashes, sexual dysfunction, osteoporosis, metabolic syndromes, and false and physical performance problems. And also, advanced prostate cancer cannot be cured, and it affects first patients whose disease has spread beyond the prostate or are symptomatic, and also for patients with biological recurrence only, which means that there is only a rise in prostate-specific antigen with no evidence of disease. Next, I'm going to talk about bladder cancer. Regarding age is an independent risk factor for developing this cancer, but the median age at diagnosis is 69 years for men and 71 years for women. and the peak incidence is at 85 years. With advanced age, there is an increased risk of detecting higher stage and higher grade cancers. So, when we consider therapy for older patients with bladder cancer, the overall benefit should be weighted against adverse effects and remaining life expectancy. Now, let's talk about renal cell cancer. The average age at presentation is actually 64 years in both sexes, and currently, more than 60% of cases are diagnosed incidentally, and this is compared with the 1097s when only 10% of cancer were found by chance. Thus, more patients are diagnosed with early disease. For treatment options, firstly, for local disease, can be surgery like radical or partial nephrectomy or ablative therapies like radiofrequency cryotherapy. Also, I want to mention that the growth rate of a small cell of the small renal cell cancer is low, and metastatic disease occurs in 1% of patients. In asymptomatic patients or in patients who are frail with limited life expectancy, we should conduct an active surveillance. Now let's talk about hematologic malignancies. We're going to start with acute myeloid leukemia. Acute myeloid leukemia is actually refractory to treatment, and this is because it has a smoldering course for which all the supportive care is administered. Unfortunately, increasing age is a poor prognostic factor of AML, independent of cytogenetics. And for patients with myelodysplasia who have no excess blasts or overt leukemia, but they are neutropenic or have recurrent infection, they may actually benefit from intermittent granulocyte colony stimulating factors. And also, the value of immediate chemotherapy for older patients has been established, but the choice of treatment remains controversial. Next, I'm going to talk about chronic lymphocytic leukemia, and it is the most common form of leukemia in the Western world. And the median age at diagnosis is actually 61, and the diagnosis is most often made incidentally also. Regarding treatment, generally, with treatment it was held unless required to control a life-threatening or asymptomatic complication like infection or bone marrow failure, and about 25 years of patients develop autoimmune anemia or thrombocytopenia, so we need to investigate the mechanism of any decline in peripheral blood cell counts in these patients. Now I'm going to talk about lymphomas. I'm going to talk about non-Hodgkin lymphoma and Hodgkin lymphoma. I'm going to start with non-Hodgkin lymphoma. Prognosis is actually worsens with age. Older patients may be more susceptible to the complications of intensive treatment. I'm going to talk about two types of non-Hodgkin lymphoma, diffuse large B-cell lymphoma and follicular lymphoma, and they are the most two common forms. For diffuse large B-cell lymphoma, the outcome of the chemotherapy regimen is appeared to be significantly improved by adding rituximab. And for the follicular lymphoma, the treatment is still more controversial, but the localized form are curable with radiation. For Hodgkin lymphoma, age incidence curve is bimodal with a second peak late in life. But compared with younger patients, older patients with advanced disease respond less well to therapy and have shorter survival. For most older patients, they tolerate modified versions of chemotherapy without life-threatening and bone marrow toxicity. Now I'm going to talk about multiple myeloma and monoclonal gammopathy of uncertain significance. So I want to mention the classic triad, which include bone marrow plasmacytosis more than 10%, lytic bone lesions, and monoclonal gammopathy in serum, urine, or both. Monoclonal gammopathy of uncertain significance is common in older people but must be distinguished from myeloma. And also, I want to mention that low-risk monoclonal gammopathy of uncertain significance can progress to multiple myeloma or lymphoma, and actually it is 1% each year. So treatment required for symptomatic or progressive lytic bone lesions, recurrent infection, or serum, and if the serum paraprotein increases. I'm going to mention the very important points in this presentation. Number one, the incidence and prevalence of cancer increases with age, and older adults more often present with advanced stage disease. Screening older population for colon and breast cancer can lead to early detection of more curable lesions. Older patients can have less physiologic reserve than younger patients, but unless a specific comorbid illness is influencing their baseline organ function, cancer treatment with curative or palliative potential should be offered to most patients in most settings, regardless of their age. And also, in general, surgery, radiation, chemotherapy, and hormonal and biologic therapies are safe and effective for fit older patients. And regarding cancer treatment, especially chemotherapy, it should be, as Dr. Safa mentioned, individualized, with appropriate precautions taken relative to the patient's comorbidities, vital organs, function, and underlying health status. This is best done with a comprehensive geriatric assessment and interprofessional approach. And I want to also mention these recommendations that are based on the American Board of Internal Medicine Foundation's Choosing Wisely campaign. First, do not recommend screening for breast cancer, colorectal cancer, or breast cancer without considering life expectancy and the risk of testing, overdiagnosis, and overtreatment. Second, assessing remaining life expectancy should involve a comprehensive evaluation of health status and include disability, comorbidity, and geriatric syndrome. And actually, this is the end of our presentation, but to make this presentation more active, I need someone to read this case for us. So, are you listening? Okay. Case one. A 74-year-old man comes to the office for routine care. He feels well, and he has smoked 1/2 pack of cigarettes daily for the last 35 years and has 1 glass of wine daily. 3 years ago, screening colonoscopy revealed two 1.5 centimeter tubular adenomas. 9 months ago, he received a diagnosis of stage 4 prostate cancer metastatic to regional lymph nodes. He was treated with hormonal therapy and 6 cycles of chemotherapy. With docetaxel, treatment was complicated by hospitalization for febrile neutropenia. He finished chemotherapy 3 months ago. His PSA level has been undetectable since discontinuation of the treatment. His blood pressure is normal and performance status is good. So, according to the recommendations from the United States Preventive Service Task Force, which one of the following would be the most appropriate cancer screening for this patient? Is it colonoscopy in 2 years, colonoscopy and chest radiography now, colonoscopy now, or no screening? So, anyone could answer this question? So the answer is actually colonoscopy now. Because as we see, this patient is 74-year-old and he has a history of smoking, and the 3 year ago screening colonoscopy revealed two 1.5 centimeter tubular adenomas. So as the recommendations of United States Preventive Service Task Force, he should undergo colonoscopy now. For the second case, an 82-year-old man comes to the office for routine follow-up. His history include long-standing diabetes mellitus, hypertension, and medication include hydrochlorothiazide. He does not require insulin. Over the last year, his creatinine level has slowly risen. His laboratory findings show hemoglobin 10.3, creatinine 1.8, albumin 3.1, total protein 6.5, urine microalbumin to creatinine ratio is 455, serum protein electrophoresis show no M spike, and there is a slight restriction in gamma region. Quantitative immunoglobulins showed IgG 550, IgA 45, IgM 25, his white blood cell count and platelets are normal, and also his electrolyte levels are normal. So which of the following is the most appropriate next step? Is it technetium 99 bone scan, serum immunofixation and serum free light chains, electrophoresis and immunofixation of 24-hour urine sample, substitution of lisinopril for hydrochlorothiazide? Actually, the answer is B, which is serum immunofixation and serum free light chains. Because this patient is 82 years old, he does have a diabetes and hypertension, and his laboratory findings showed anemia with impaired renal function, and also his serum protein electrophoresis showed no M spike, but there's a slight restriction in gamma region. And this slight restriction in gamma region needs further assessment and further clarification. As we know, multiple myeloma is a monoclonal proliferation, so we need to know the exact monoclonal antibody or even the free light chain that involved in this proliferation. So we need to do a serum immunofixation and a serum free light chains. The last case is an 81-year-old woman comes to the office because she has had a vaginal bleeding for the last 10 days. 3 years ago, she had estrogen receptor positive, progesterone receptor positive, and also HER2 negative breast cancer. It was treated with surgery and radiation, and she has been on adjuvant tamoxifen without known recurrence. In her 30s and 40s, she had frequent flares of ulcerative colitis that required treatment with high-dose corticosteroids and ultimately colectomy. Screening bone at age 65 revealed osteoporosis. She was treated with alendronate. She had 4 vertebral compression fractures over the next decade. On examination, she seemed frail but in no distress. There is kyphosis of the spine. There is no oral mucosal bleeding or skin ecchymosis. All other findings are normal. Which one of the following is the most likely cause of vaginal bleeding in this patient? Is it uterine cancer, drug-induced thrombocytopenia, metastatic disease from recurrent breast cancer, cancer-associated disseminated intravascular coagulation? So the answer of this question is A, which is uterine cancer. As we see, this patient is 81 years old, and she had estrogen receptor positive and progesterone receptor positive breast cancer. She is actually treated with radiation and surgery, but she have been treated with tamoxifen. And as Dr. Safa mentioned, that tamoxifen has a negative effect on the uterus and can be complicated by abnormal vaginal bleeding, and this could be due to a abnormal uterine hyperplasia, and which actually can lead to uterine cancer. So the answer is A. And thank you, everyone. This is the end of our presentation. Thank you for your listening. And of course, thank you, Dr. Nader. Thank you, Dr. Safa. And I want to mention that these slides are copyright to the 2019 American Geriatric Society. Thank you. If anyone has any question, any comment, please do not hesitate to say it. Thank you.
Oh, thank you, Dr. Roaa and Dr. Safa. Dr. Nader, do you have any additional information or comments?
Thank you so much, both. A great presentation. You did great. No added information, but thank you.
Okay, we can move to the second agenda for today. I will be the presenter. Okay, is it my screen visible for everyone?
Yes, Dr. Mahasin is clear.
Okay. Today we are going to review the most common U.S. medical abbreviation, slang, and electrical medical record terminology. These are essential for IMGs transitioning into U.S. Clinical environment because they appear in your almost every conversation, notes, and order. So, in the U.S., medical communication is extremely fast paced, and clinicians rely heavily on a shorthand. Abbreviation appear in your order, sign out, and runs, and electronic documentation. Slang is common in spoken conversation, especially during sign out or emergencies. Understanding this terminology help IMGs integrate it smoothly and avoid error and communicated confidentiality, confidence. Sorry. So these abbreviations are encountered daily. NPO, PRN, and PID, TID, QID appear in almost every order. Say SOB is commonly used but easily misunderstood. D/C is a common one, and the most dangerous abbreviation because it can mean discharge or discontinue. So context is very important. We have also medication administration abbreviation are essentially for reading and entering orders. OP, IV, IM, and SQ describe the route of administration, especially abbreviation like Q, 4H tell you exactly what medication are you given. Stat always mean urgent or immediate the joint commission this included use a few because it can be misread instead of right unit fully. So we have a lab and vital abbreviation. These are the most common lab and image abbreviation you will see in EMR result. CBC and CMP count as a basic panels. CXR stand for chest X-ray, and UA for urine analysis. SPO2 is extremely important for monitoring oxygenation. Recognizing these at the glance help you interpret EMR data quickly. So Slang is not used in formal documentation, but it's everywhere in spoken communication. You will hear it during morning rounds, rapid response, and also sign outs. Understanding slang allows you to follow conversation accurately and avoid misunderstanding. So we have here this slang a phrase describe clinical situation quickly. Like tank means the patient is suddenly getting worse. Rocked labs mean something is very abnormal. For example, potassium is 2.9. Dropping refer to falling oxygen saturation. Soft pressure means the blood pressure is borderline low. This phrase helps team communicate rapidly during high stress situations. So we have SOAP note structure. The SOAP format is the foundation of the U.S. medical documentation. Subjective is what the patient tells you. Objective is every measurable, vital exam labs. Assessment is your clinical judge, including your differential, uh, plan outlines, test medication, and follow-up steps. This structure keeps the documentation clear and consistent. The discharge summary is one of the most important document in the patient care. It communicates the entire hospital course to our patient team. You must include what brought the patient in. There is a hospital course, key procedure, medication change, and follow-up plans. Especially important. Finding result outpatient provide rely on this is to continue care safely. So like smart phrase or shortcut built into EMR like EPIC. You type a dot followed by a keyword, and it expand into a complete sentence or even entire template. They save time, reduce error, and help maintaining constant documentation. Most residently use them extensively. So we have example here. Okay, there's our common example typing IV.IV automatically insert a standard phrase about starting IV fluid. Normal exam generate normal physical exam section. Dot phrase like dot PMH or dot DC extend into structured templates. Creating your own personalized dot phrase is highly encouraged. So we have example here. Okay. Smart phrase significantly reduce documentation type, especially in busy rotation. Sorry. Okay. Smart phrase significantly reduce documentation time, especially in busy rotations. They also help ensure your notes follow standard format. For IMGs adjacent to the US EMR system, dot phrase prove reliable structure and improve note quickly. Sorry, guys. I'm not reading the example for you. Okay. We have example for the dot system. Okay, this sentence is good example for real clinical communication. We have here SAT dropped to 88% on room air, means that the patient is desaturating and need oxygen. Also, we have chest X-ray stat, means that immediate chest image. Also, we have lab rocket potassium 2.9. Also, we have replace PRN, means potassium should be replaced as need as based on the protocol. Also, we have PP soft. This mean borderline low blood pressure. Understanding this shorthand lets you respond rapidly and safely. Okay. Okay. To summarize, the U.S. medicine relies heavily on abbreviation and shorthand. Slang is common in the daily communication, documentation, follow format, especially SOAP and discharge summaries. Smart phrase save your time in EM or work. Okay. This resource provides a comprehensive list of abbreviation and the slang used in the U.S. clinical setting. They are great for self-study and for build your own reference list or study desk. Oh, thank you, guys.
Thank you so much. This excellent presentation.
Welcome, Dr. Nader.
So basically, we want you to know that at least in the past, the EMR, when they introduced them, the electronic medical records, people were slow in typing, and this came as a tool to help them when they repeat certain sentences, when they see patients, mostly like repeated visits. So when you see the patient first time, you do the HMP, but the second time, third time, you're gonna do a follow-up notes. And most of the time you will be using common sentences that you type in your notes. So the shorthand for that was doing a dot and then you put the phrase, for example, no change in the examination. So it's only one sentence, but you can put, when you say that, a full exam, which is normal. Like you're gonna say head normal, neck is normal, or you want to say eyes non-ecteric, no epistaxis, or lymph node, cervical lymph nodes not palpable, something like that. So it will just elaborate on your exam the way that you want it. Patients with congestive heart failure, most likely you will have something in their lungs. You can hear some crackles, and they have edema. So if you are decreasing them, so the first day, second day, most likely these symptoms or findings will be there. So you can just copy paste this. Instead of you to copy paste, you can just do the dot phrase abbreviation. Nowadays we have AI, so you can use dictation, and then the AI will transfer or will get the information for you faster. So speaking about that, we have Dr. Rufida with us. Welcome, Dr. Rufida.
Hello, Dr. Nader. Thank you.
You're welcome. How are you?
I am good. How are you?
Very good. So before we ask you to help us with the topic that you want to discuss, maybe you can give us a little bit background about you and then how you use EMR or AI. Thank you.
Sure, Dr. Nader. So I am Rufida. I'm one of the previous fellows at the TGRF. I am currently working as a PGY2 neurology resident at SUNY Upstate. Like as always, attending this fellowship, being part of this fellowship, it does prepare you a lot to residency. I would say, especially for you as an IMG, the first 1 or 2 months of residency, you just try to figure out the system. And part of figuring out the system is you figure out the documentation, you figure out the EMR. As the presenter was talking earlier, and as Dr. Nader was talking earlier, like abbreviations such as PRN, if you don't know what does that mean, it will be helpful to know what does that mean so that when it is in the EMR, you would be able to understand what's going on. So it's something that it takes a lot of energy for most of IMGs initially when they start residency, just to figure out what does PRN means, what does PP means. And then documentation is the pain of existence of all the providers and all the residents, because it takes a lot of your time. You see patients, you're around on patient, it doesn't take a lot of times, but you will end up spending a lot of big number of your day in writing or documenting your encounters with patients. And it's important. It's important because if, for example, if I was working during the day, there's someone who came during the night, they would know what's going on with this patient. It gives you an idea with regard to if there is a change that happened with this patient, and also it guides management. It's very important for patient care. So it's very important to document accurately and at the same time efficiently. Things such as dot phrases and smart phrases, as Dr. Nader and the speaker were talking about earlier, it makes everybody's life easy, even if the patient exam has some findings. If you put dot exam and then you have the exam, the normal exam there, not necessarily every single patient they're going to have an abnormal finding. For example, as Dr. Nader was saying, if patient has jaundice, then you can just change the head and neck exam part to patient appeared jaundiced, and then you keep the rest of your exam as it is, instead of writing the whole exam from zero. So that saves you a lot. So I think it's a great lecture, and it's a great thing for those who are preparing for residency to be exposed to. I think it's a great idea.
Thank you so much. So we are great to have you, Dr. Rufida, and we want you to share your experience and tell us some of the tips regarding those who planning to go for residency interview season now. How do they prepare for that and so on? Thank you.
Thank you, Dr. Nader. Thank you for giving me this opportunity. I just have some tips for those who already interviewing this year and those who are already planning to interview for residency. You guys are already in the right track. Since you're already doing your interviews, that means you already did the great work, you did your exams, and also those who are, doing their exams now, preparing for the interviews, you're already, doing the job. So you just need one interview for you to match. And in order for you to do that, you just need to to prepare pretty well, and then own everything you did for the last years, because we went to medical school, we did the USMLE exams, we did a lot of experiences in order for us to, to train to be physicians and to be providers in order for us to independently practice in the future. So it's a one step towards you becoming an independently practicing providers. I just have a couple of tips for those who are interviewing. The first thing I want to talk about is that it's sometimes kind of difficult to balance between, owning the things you've done or coming through as an arrogant. So what I would say is that most of us, sometimes we feel, we may come through as an arrogant. So we become shy in showing case the things we've done, whether it's a clinical experience, whether it's a volunteer work, whether it's a research. It's very important for you to showcase the things you've done throughout your career. And the reason why is that because we have a limited seats for residency. And most of the people who apply matches, but there is a limited number of seats, and you compete with people from all over the world, not only US graduates or US IMGs or US AMGs, but also you compete with other IMGs from all over the world, and they've all had their paths. And if you don't showcase what you have done, you don't find yourself having a chance to compete for a residency position. And I'm pretty sure most of you guys, since you're already here, you're already interviewing, you have done a lot of things. Even the small things, even if you just volunteered, you had a one day, you went to a rural area, you gave a lecture about something, own it and talk about it in a positive way. Because these are the things that makes us who we are. For example, during medical school, I walked 120 kilo. And it's something that I talk about all the time in my interviews to show resilience. I did walk 120 kilometers over 5 days, and it's something that has nothing to do with me being a physician or being a provider, but I talk about it to show that I'm someone that's resilient and I'm someone that can, take on hardship, because it's something that you do need during residency. So this is the first part I want to talk about. The second part is red flags. So a lot of us, when we have a red flag and we are aware about it, we tend to try to explain, sometimes we try to explain that, this happened because of this happened because of this. I would say avoid mentioning your red flags, even if you know it did exist, because sometimes interviewers may not even, know that it exists. Maybe they don't think about it as a red flag. What we think about as a red flag, maybe they don't think about it as a red flag. So do not mention whatever you think it's a red flag unless you were asked about it. And then once you're asked about it, be honest about it. Talk about what happened. Talk about why do you think it happened. Talk about, make it a positive experience in a sense that, why it happened and what did you do to improve it and what did you learn from it. And this goes for everything. This goes for the questions that they ask you, talk about the mistake you did, talk about the negative experience you had, own everything. And then make it a positive point in a sense. What did you learn from it? How did it contribute to you as a human being? And then for us as Sudanese specifically, the most unique thing that to us is the war. And this is something that during my experience, I was one of the first people who interviewed after war. So I interviewed right afterward. I interviewed in 2020, like end of 2023, beginning of 2024. So it was, we were the fresh people. So most of the interviews I go in, they either ask me about how are you now? Or they either ask me tell me about the war going on in Sudan, how did that impact you? Or they just bring it up to see how you're going to react, because it's a really traumatic experience. And it's something that it's very sad that it's happening in our country. But at the same time, you need to be prepared to talk about it in a sense that you don't have to make it appear as something very positive, because it's going to appear that as if it's not real, in a sense that, to show people that, we're not affected by this, and at the same time, you don't want to talk about it too negative to appear that you're actually very much affected by this to the degree that they worry if you become a resident, you may not be able to handle stress and to handle things. And by our nature, we're known to be resilient. Most of the Sudanese that I was born and raised and grew up in Sudan, I know that most of us, we do have the qualities of resilience. The war is I feel like it's the proof that, we're very resilient people. We're people that we can take on too much. We're very patient. And these qualities, we do have it in us. So take it as an opportunity to show these qualities. Take it as an opportunity to show also that you're someone that can empathize, and at the same time, you do embrace things that happens in your life. The next point I wanted to talk about is also, before going to any single interview, try to research, do a thorough research, whether about the program, in terms of what they have, what are they proud of, is it a good environment, is it not a good environment? If you have questions with regard to anything that you're concerned about, anything that you want to know more about, anything that, for example, if you have a specific interest, for example, I want to do intervention in neurology. So most of the programs that I was interviewing in, I was interested to know these programs, how heavily they are involved with regard to intervention neurology, with regard to IR, with regard to stroke. So it's things that it mattered to me, because at some point I knew that this is what I want. So see what mattered to you, and then research the programs, and then ask questions. Research the people that they're going to interview you, because you also want to know what is going to be appropriate to say, what's not going to be appropriate to. So who is going to be someone that you would want to have a simple conversation with? Who would be someone that you would want to be careful with? Who would be someone that you want to talk to them about research? And then research the area. Always what I used to do is that I always reach out to people. If I know there is a resident, most of the times I try to reach out to our people. If there is a Sudanese in the program, I try to reach out to. If there is any other nationality in the program, I try to reach out to, and then gather more information. Sometimes they also talk to the programs that we do know this person. And then, people trust their own people as well. So that's the other thing. And then always, sometimes they can also ask you, as it's something I touched based on kind of at the beginning, but there are certain questions that sometimes they're kind of difficult. There is the general questions, which is like, they're going to ask you to tell me about yourself, tell me why you want this program, tell me why you want internal medicine, neurology, or peds, or surgery. So these are the common questions that everybody prepares for, but sometimes you also get encountered by behavioral questions, in a sense that they want to see what you're going to do if you are in this situation. If you are ever to encounter any question that you feel like it's a difficult question, or something that you may need to pause to think about it, do not be afraid to take pause, maybe 5 seconds, just to think about the question itself, or 3 seconds, or sometimes just for you to absorb the question, to think about it, and then to give the answers. And always try to make the answer up in a positive way, in a sense that, what did you learn from this, or how you're going to make it a learning experience for you, even if it's a difficult situation. And then some other programs also could ask you clinical questions. And for these clinical questions, what they want to know is how you're going to approach this question. They don't want to test your medical knowledge, because they already have a proof. You already passed your USMLE exams. They're one of the very tough exams. So you already passed your exams. They already know you have a good medical knowledge, but they want to see how you're going to act when you're on night, for example. You don't have a lot of support. If your senior is doing admission, or your senior is doing something, as a PGY1, what you're going to do. So they want to see your approach. They want to see that you do know how to triage patients. Do you know how to triage the sick patients from the patients that, you can see them after sometimes. So always think about it. Always try to analyze, put a differential in your head, and then investigate accordingly, treat accordingly. So this is what they want to do. They don't want to test your medical knowledge, but they actually want to see how you can systematically approach the case, and always ask questions. I would say, if you are encountered with a case, always try to put in your head that it's going to be important for you to ask questions, even if there is somebody who gave you a history, because a lot of times patient comes through the ED. The ED takes a very brief history, and then this patient, end up having this history of presenting illness, but you want to have your own history of presenting illness in a sense that you do not anchor to what you were told by the ED, but you want to have your more information based on the scenario was given to you. You think of a differential, you ask questions based on that, you order investigations based on that, and then you treat the patient accordingly. So this is what they want to do. Every single clinical case they give you, if you put this approach in your head, you will be able to assess it. So to summarize, with regard to the questions in general, have an approach in your head. Always ask yourself a question: what does this person wants to know about me? They can ask you all type of questions. You can say all type of answers, but there is almost always a point behind asking certain questions to know how the person in front of me thinks, how the person in front of me does things. The other thing I wanted to talk about is that also the setting is important for those who are interviewing. The setting is important. Your backgrounds, you being at the center of the screen, looking at the camera, looking at the person that's talking to you, and also the way you dress. For males, it's specifically important for males to, it's for everybody to wear business casuals, but for males, it's more preferably to wear suits. For females, you can wear business casual, you can wear colors that are not, they're more formal or business casual. And then also the light should be appropriate. There should be no noise. Try to sit in an area that doesn't have an interruption or noise. These things are kind of important. The last thing I want to talk about is always knowing what you know already. Try to practice as much as you can. Try to get feedbacks as much as you can, whether it's with your colleagues, whether it's from your seniors. Try to practice as much as you can. It's something that I did with my friends. I had two of my friends, they were applying during the year I applied. And we used to wake up almost every day. And then if not every day, every other day, we have a practice session. We give each other feedback. I practice between me and myself, even if not with them, just to see how I say things. And then every time you practice, you find a way to talk about yourself in a better way. So that's the final thing I will give to you. And then I'll let you guys ask me if you have any questions.
Thank you so much, Dr. Rufida. Any questions from the group?
Yeah, so.
Hello.
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 Go ahead. Go ahead.
Yeah. Thank you, Dr. Nadir, as always. Thank you, Dr. Rufida, and everyone. We appreciate your time.
Of course.
Could you please? Yeah, thank you. So, could you please tell us about the second look?
Okay.
Any advice? Thank you.
So what I do understand from the second look is that it doesn't affect your ranking. But it's gonna affect you ranking the program. It doesn't affect the program ranking you, because I think by NRMB rules is that a lot of times they do the second look. Most of the times they do it after the rank list has been already submitted. If there is a program that actually does that before, it should make you, reconsider about, maybe ranking this program. But most of programs, they do the second look after submitting the NRMB list or the ranking list. So it doesn't affect the program assessing you. But generally speaking, if you go for a second look, you want to, it goes two ways. It goes one way that you want to know more about the program. Yeah, you will be interacting with residents. You'll be interacting with employees, and you're gonna see how is the environment. You're gonna read the room. At the same time, you're gonna see the area. Is it somewhere that, for example, I prefer the suburb. Is it somewhere that's or me, I can live in? or some other people may prefer the city vibes and also, having a place that's busy, so is it somewhere that's suitable for you? So that's from your part. The program part is that you wanna look presentable, you want to be decent, because these are going to be, if you are to match in that place, this is going to be the place that's you're going to be working on, or you're going to be working at for a good amount of time. So that I would say for the second look. أنا صراحة I don't remember I went for any of the second looks. But I have some of my friends, they did actually go to the second look, and they do find it helpful to guide them to make the decision of the ranking. It's going to be the next step that's going to come for you guys to figure out which programs you want to rank high. And I think it could be helpful in a sense that it's going to provide you with more information to help you.
Okay, that's what's so helpful. Thank you so much.
Of course.
You said, yeah, you don't remember that you went to second look, but could you give us advice on what to talk about, the attire, or like all these details, if you have
Sure.
experience with that, please? Thank you.
Sure. So the attire in general is just business casual. So, you can wear a regular shirt and then just a business casual trousers. Sometimes if it's tucked or not, it's just, something that's just business casual. It doesn't have to be something excessive. You don't have to always, especially for the second look, you don't have to wear a suit, for example. If you wear a suit, that's great. If not, it doesn't have to be. You just have to wear something that's business casual.
Great. Thank you so much. We appreciate you so much, Dr. Rufida. And
Of
we miss you
course,
this
of course.
season so much.
I know. I'm sorry.
Yeah, right.
Second year
It's
is tough.
okay.
I am really
Yeah,
sorry.
I
Second year
know.
is,
I know.
yeah,
Good
yeah.
luck with your residency too. Thank you.
Of course. And if you guys need me, I think I do have a vacation in 2 weeks, so I should be able to help.
Okay, great.
Yeah.
We'll sure will contact you. Thank you so much. Thank you, Dr. Nadir. Thank you.
Thank you both. Any other questions to Dr. Rufida or any comments?
And also, one of the last things I forgot to mention is if any of you did a step 3, published a paper, started working in any project, if there is any milestones that's, happened after you submitted your match application, sometimes what I did in my year is that I did use it as, as a way to send a letter of intent. So there is formats for letter of intent that's available. I can also send it to you guys. You can send to the programs, and technically you're not supposed to tell the program that I'm going to rank you high or not, but you're allowed to send a letter of intent. So what I did is that I made it in a sense that it's an update at the same time, a letter of intent. So for example, I think I had a paper with Dr. Nadir that I presented at the American Academy of Neurology, and that kind of happened later on. So I did send, it was after the season, so I did send the programs that my paper actually got accepted at the American Academy of Neurology, and I'm going to be presenting this, and I have another thing I'm working on, and I already got certified for those who are not certified. So these are like an update I sent to the program, and beside it, I also told the program that technically I want to join you, or, you're showing your intent that you want to join the program.
Sounds good.
All right. If you guys have any questions, let me know. If any questions comes in, I can also track the chat. I'll be keeping an eye on the chat to answer your questions.
One more question I have for you. Maybe you can help. Do you use any AI in your residency or personal What do you think in
Yes.
medicine? Yeah.
Yes. So there are a lot of things that we actually use. So I think AI is taking over
Yeah.
as of now.
Yeah.
So, and I think there are things that we actually used here, for example, such as MD Calc is something that we use all the time. Up to date is something we use all the time. But specifically in my program, so as you talked about earlier, Dr. Nader, we do use dictations. I find it very helpful. I am someone that I'm still, learning how to type faster, but I dictate pretty fast. So I use the dictation instead of, typing. And also I find it better than typing because it doesn't give you occupational injury, because with frequent typing, you can get, injuries and gangliomas and stuff, gangliosis and stuff. But I use dictations. We have Dragon, I think, in my program. So we use Dragon. It's pretty fast. You can dictate a note in like 5 minutes. So it's pretty good. The other thing we also use, we have Pulsera. So Pulsera is like an application that's, it links EMS to specific institute. And I think it's something that's institute specific. If there is a stroke code that's coming, it alerts us, and then we know that this patient is going to be here in like 15 minutes. And if you're going to run the stroke codes, you're going to be upstairs, you're going to be reviewing the patient, you're going to be calling family, trying to gather more history. And then by the time patient is almost there, 3 minutes to patient just arriving to the ED, you go. So Pulsera is one of the things. The other thing is some program I also use is AI Doc, is an application that every single image that a patient in the hospital did have, it actually sends you an alert that this is an image, especially in your department. And you can even choose the department. So you can be alerted. So if you have one of your patients, you're in the ED or you're in stroke code, you can actually use it from your phone to view images. And it's pretty good. Another thing I can think of in terms of AI is in reading EEGs, specifically for those who are doing neurology. So we have Cadwell, which is an application that it helps you to read EEGs. So there is an AI tool to it that, for example, if you have a patient in status and then you're aiming for burst suppression, it tells you how much, based on the drips you're giving them, it tells you how much these patients are burst suppressed. It has like colors, different colors, and then it has a percentage. It tells you how much of the discharges are, or this patient is, are they close to burst suppression. So I feel like it's taking over, and it's very important to be familiar with what you have in your institute, because it also makes your life pretty easier.
Sounds good. And the other question I have, we asked before other residents, in your daily life, day-to-day, first year, second year, do you use any mobile applications that help you navigate, learn, whatever, make life easy for you?
Absolutely, absolutely. So up to date and MD Calc are things we use. The most helpful thing I found as an AI is open evidence. And open evidence, you need to be very careful in using it. So open evidence, it pulls the strongest evidence from all the literature. If you want to ask about anything, if you want to ask about headaches, if you want to ask about GI bleed, it pulls all the evidence and it gives you the summation of what does the AI think. But what I find it even more helpful is that it gives you references at the bottom. Because sometimes not 100%, these are new things, they're still being trained, because AI, how it works is that they do, they do learning of the software learning, and then it's still something that's, getting improved. So what I do is I get the general idea about what I want to know, and then I go to the references. It gives you some really good references. For example, references from journals such as New England Journal of Medicine, and JAMA. So these are some really good references. So I go to the references and I read about the original article, or where these guidelines came from, or where these informations came from. So open evidence, I find it very helpful. Whenever I want to research about, if you want to research about anything, you can just open evidence and then do it. The other thing I also find that's helpful is for those who are going to be especially in internal medicine, also in neurology, whenever you run a code, there is an application. I think it's called AHA ACLS. So it's actually part of the American Heart Association. They have this application. I think you pay like $3 or $2 per month or per prescription, I believe. And then whenever you run a code, it gives you a pathway with regard to what to do. From the beginning, you press, is it a bradycardia? It asks you, is it a bradycardia? And then if you say yes, is it sinus bradycardia? And then it tells you, what do you do next? And then if there is a cardiac arrest, it tells you it asks you what's the rhythm, is there is a pulse, and then it tells you what to do next. Do you give epi? Always you do compression? Do you do epi? And it tells you when do you do compression. It also tells you how much are we doing chest compression. It keeps track of things. There is an area also you can log in the medication you give. So there is a person always in codes that do the documentation, but you can also keep your own as a provider running the code, your own documentations. So these are things that's really helpful for you as a resident.
Great. Also, another question. We are trying to develop some mobile applications using AI to help patients with certain conditions. Let's say a patient with diabetes, they can track their blood sugars, blood pressure, they can track their blood pressure and so on. And it's very easy nowadays to create these apps. For your patients, what do you think could be like an app or ideas for apps that we can create for any type of conditions you think about?
I think it's a great idea. For example, me myself, I'm pre-diabetic, so I got this blood sugar strips that you check your blood sugar, and then it actually comes with it as an application. I think it's present in Amazon. So it comes in an application that it logs your blood sugar and it tells you your control. I'm someone also, I like to keep, for example, track of my steps and stuff. So I think these applications are pretty helpful, especially for those who are, having like a business schedule, patients themselves, like even if you don't have a business schedule, and if you're trying to improve your health, you already have a health condition, you're trying to be on top of it, I think they are pretty helpful. One of the things I can think about, for example, in terms of diabetes is to incorporate lifestyle. For example, just thinking of what I just said now, to incorporate, for example, lifestyle modification, exercise, for example, goals, blood sugar goals, to incorporate physical activity goals, maybe 30 minutes per day for how many days, and then keeping track of your A1C, and to remind the person to check their A1C every now and then. I think it's a great thing to do.
Sounds good. Any questions from the group?
Yeah,
go ahead.
I have another question, Dr. Rufida. So, from your experience, do you recommend like a book to read, a course to take before start residency? A few months before you start in June, so to just help you to be on track since the entry year.
So what I would say is the most thing I would recommend for everybody to do is that those who didn't do their step 3, try to study step 3. Me myself, I did step 3 during the end of my PGY1, and I think it was like it was not a bad experience, because I feel like it's helpful to do step 3 after you start residency, but it's also good to start studying for it before starting residency, because PGY1 is very busy. And at the same time, the information from step 3 does help you a lot in terms of practice, because they're all related to your practice. So I would highly recommend to study for step 3. Other than that, I would not recommend you spend the time you have. I would say now the time you have, focus on, preparing pretty well for your interviews. I'm someone who always encourage people to stay knowledgeable. if there is an article you come across, if there is a small book you feel like it's helpful for you, read it. I don't have a specific recommendation for a book, but if you feel like there's something small you want to keep, yourself up to date, you want to keep yourself, retaining the information you already know, in a sense that you don't stay, you don't read and then you forget the information so you already know. I'm someone who always encourage that, but I would not say try to spend the rest of the time you have before starting residency in doing so, because residency is going to be tough and you need to build the energy for it. So try to enjoy the time you have, try to keep yourself updated. If you did not do step 3, try to study step 3, but I would still recommend you do step 3 during your PGY1, because there is an element for practice that myself, I found it pretty helpful when I did it after finishing my PGY1. Not necessarily at the end of PGY1, maybe at the beginning, maybe after 3 months, 4 months, 6 months, maybe at the end, whenever you find time. And I did it actually after my vacation. So it was I did not have a bad experience with step 3, I would say. And for those who are specifically aiming for competitive fellowships, for example, interventional cardiology, there are certain fellowships that are kind of competitive. So I would say try to aim for a higher score in step 3. So that's my only advice. But at the same time, try to have fun.
Okay, that's good advice. Actually, I'm done with the step 3. So it's like I was asking after the match and before you start, if there is like like a refreshment book or a course you could take. But thank you so much. That was helpful. And yeah, we'd enjoy it.
Of
Thank
course,
you.
of course.
Yeah, thank you so much.
Thank you. I'd like to add, earlier when we had our residency, we used manuals like Washington manuals. And if I'm not sure if you are going internal medicine, family medicine, it depends. But wait until you start. There are some either applications or booklets that you can carry on. Very small ones for infectious disease, like what antibiotics you are going to use in this condition, that condition, for example. There are some pathways, and depending on your institution, they may offer that they can buy you this, is it online or actual books. So for now, as Dr. Rufida say, maybe just take it easy. If you have time, if you have contact in your area, you can try to go and do clinical either observership or work, help if there are some clinic for like people with no insurance. Sometimes they need help, the physicians there. So maybe you can also just get used to the system, the AMR, as we mentioned here, the dialogue between the patient and the physicians and the nurses and the environment itself, so that by the time you start, you will be familiar with the environment. Thank you.
I absolutely agree with Dr. Nader, because the first, as I said, like the first to second months of residency, we're going to try to figure out the system, how to deal with, you have, like, we work with a lot of other employees, and how to be able to navigate your way with nursing, with the staff, how to communicate, with patients themselves, how to figure out the EMR itself. I think pursuing an observership or volunteering at a clinic at this point of time, I think it's going to be a very helpful thing to do.
Before we leave you, Dr. Rufida, do you have any ideas about doing research that we can involve some of the fellows here? Any ideas, like new research projects or something?
Sure. So I feel like research is something, like, there is always there is always you know, something to do research about. And one of the easiest things I used to find in terms of doing research, specifically now for the fellows, is doing things such as systematic review and meta-analysis, because you trying to pull out or bring evidence from the literature that's already present. You don't need to collect patients' data, because it's very difficult to, you know, to obtain patient data at this point of time. For those who are interested in, for example, in neurology, there is a lot of data, that there is a lot of areas in terms of research. For stroke, for example, stroke has, you know, still growing. There is a lot of things could be researched about stroke. And then, for example, different treatment approach. Now they're actually viewing, you know, there is a clinical trial going on about it's called Sister Trial, where they're trying to figure out how to give this new medication to act instead of thrombolytics. So there is a lot of areas, for example, for research in stroke. There is a lot of areas in research in neurology in general. In internal medicine, definitely there is a lot of areas in research, specifically with the new medications, the Ozempic. There is a lot of side effect we're coming to learn about. One of the things I was actually thinking about early, that when there was a presentation about the cancers, one of the things that's actually causing a lot of side effects is the immune checkpoint inhibitors. And now we're coming to learn that the immune checkpoint inhibitors, they can cause anything. They can cause, as they're trying to suppress the cancer from growing, they also does have a lot of autoimmune conditions that goes on. There is a lot of autoimmune neurology we see with immune checkpoint inhibitors. They can also cause myocarditis. They can also cause autoimmune hepatitis. They can cause lymphoproliferative disorders. So they have a lot of side effects. So there is a lot of areas to do research. What I would say for the fellows is, as I said, try to work on systematic reviews and meta-analysis. They're very easy to do, especially if you're a group of, you know, 3 people plus. You can pull the data together. You can work on, you know, analyzing these data, filtering out which data is, you know, was done properly, and then try to extract the evidence from it.
Sounds good.
Yes. All right.
Thank you so much again, and we wish you all the best, and we'll be in contact, and let us know if we can be of help, but we'll be reaching out if we need help.
Of course, Dr. Nadi, thank you so much. I really praise you for doing this, and you take your time every week to help the juniors and to help everybody, you know, to pursue their careers. I really salute you for doing this.
Thank you, and it's wonderful to have you back, and really, thank you for everything.
Thank you, Dr. Nader.
Thank you, Dr. Can you please ask for, you said your vacation is like coming, could you please just give us like 1 hour, and just like we need special sessions about behavior questions.
Of course.
Yeah, the common questions like delivering bad news, and so is like, we know like the Psych protocol and stuff, but some questions I find like tricky, and of course from your experience you're gonna know better. So we'd appreciate it if you could you just give us please like 1 hour, and so using
of course.
Yeah, thank you.
Yeah, we can aim for, we can also do a mock, and then actually in action to try to, you know, to tackle things in action, and then with some objectivity. I think it's something we can totally do.
Yeah,
inshallah.
that will be great. Yeah, thank you so much. We appreciate you.
Of course. All right, everybody. I wish you all best of luck, inshallah, and I'm gonna see you guys in the future, and I hope you all end up in the programs that you wish to match in, and you become residents, you do your you know, you become all successful in your careers. Well, thank you, Dr. Nader, for having me.
Same to you. Thank you so much. Thank you, Dr. Nader.
Of course.
Thank you. Have a wonderful day. Thank you so much.
You too. Right.
So now we reach the last item in the agenda, any updates as far as what you are doing, and if you have questions, ideas, any research projects? Or any questions about the fellowship, about what you are doing and your teams? If no questions, then let me know if you need anything, and we'll help you as much as we can. I wish you all the best. Thank you again, all the presenters. Thank you, Dr. Mahasin, for leading the team and moderating the meeting. Thank you all who attended today's session, and thank you in advance to those who will watch the recording in the future. I wish you all the best, and we'll see you next week. Assalamu alaikum. في أمان الله.
عليكم السلام. شكرا جزيلا. Thank you so much.
Anytime.